My dear friends, my topic today is the role of anticoagulation in COVID-19 from a cardiologist's perspective. Now, before I start, I have to say one of the important things which is essential in the present fight against COVID-19 is humility, because we hardly know anything about this disease, and this disease is yet to be of wide age. It is still in its infancy. And the thromboembolic problems with COVID-19 has been described maybe only 6 months ago. So there are a lot of things which we do not know. In fact, there are more things which we do not know than the things which we know. So humility is essential in the fight against COVID-19. In fact, a new terminology has been described, that is COVID-19 associated coagulopathy. SARS-CoV-2 virus does not have any intrinsic procoagulant effects itself. So what is not cause of the coagulopathy? And it is also distinct from disseminated intravascular coagulation, because the major finding in COVID-19 is thrombosis, whereas the major finding in DIC is bleeding. Also, in COVID-19, the typical findings are a high fibrinogen level and a high factor VIII activity, suggesting that there is no major consumption of coagulation factors, which is opposite to what happens in disseminated intravascular coagulation. So the present concept is that the coagulation test abnormalities in COVID-19 is a result of profound inflammatory response. Most COVID-19 patients would not be classified as DIC according to the DIC score of the International Society on Thrombosis and Hemostasis. So let us see what are the major characteristics of the COVID-19 associated coagulopathy. Well, one, coagulopathy is manifest as elevated fibrinogen, elevated D-dimer, and minimal change in prothrombin time, APTT, and platelet count in the early stages of infection. In fact, the levels of fibrinogen are directly related to the level of inflammation as marked by interleukin-6 levels. So coagulopathy is definitely related to the inflammation. Coagulopathy appears to be related to the severity of illness and resultant thromboinflammation, and not intrinsic viral activity. Many times, the coagulopathy comes after the patient becomes negative for virus. So it is inflammation which is the result of this coagulopathy. And rising D-dimers, elevated D-dimers are an important marker of the coagulopathy. Elevated D-dimer at admission is associated with increased mortality. And during hospital stay, as the D-dimer rises, rising D-dimer after admission precedes multi-organ failure and overt DIC. So there is also an element of DIC, even though the major contributor is not DIC. Now it is noted that the D-dimer starts rising from about 4 days after admission in non-survivors, and the longer the duration of hospital stay, there is increasing D-dimer and more is the chances of developing sepsis physiology. Fortunately, however, bleeding manifestations are not common despite the coagulopathy. Now, there are other problems also. There are so many investigational therapies for COVID-19 now, even though many of them has not really been successful. The problem is that some of these investigational drugs have clinically important interactions with antiplatelet and anticoagulant agents. I can just show you a chart that have effect on antiplatelets, another group of drugs which have effect on anticoagulant. I'm not going into that one by one for want of time. Now, to look at the prevalence of arterial and venous thromboembolic complications, probably this is the best registry. This was published very recently in the JACC, Journal of the American College of Cardiology. What they found was that at 30 days from the diagnosis, in the ICU cohort, they have only looked at the ICU cohorts, the major arterial or venous thromboembolic events was 35.3%. In other words, 1 in 3 of ICU people developed either arterial or venous thromboembolic events. Major adverse cardiovascular events, which is cardiac death, non-fatal MI or non-fatal stroke, occurred in 45.9%, which means it's just less than half of the population. And symptomatic venous thromboembolism was there in 27% of patients. most of these patients, most of these events occurred during hospitalization. As you can see, 98, 97, and 97% respectively occurred during hospitalization. So it is the hospitalized patient who is at the highest risk of thromboembolications. And this is very important, that they found that the symptomatic DVT was largely composed of catheter or device related thrombosis. So when you put a catheter or a device in a patient with COVID-19, make sure that it is essential. Unnecessary catheters or unnecessary devices can lead to symptomatic DVT and hence problems. Now, if you look at those patients in the ICU, whereas those patients who are inpatient inside the hospital but out of ICU, one can find that the cumulative proportion of arterial and venous thromboembolism is much higher in the ICU, which is the red line, compared to inpatients who are not in the ICU. This is also true for major cardiovascular events. Again, you can see that the proportion of patients without major cardiovascular events, the red ICU is much, much less compared to those inpatients without in the non-ICU setting. So the registry sums up saying that in COVID-19, major arterial or venous thromboembolism occurs in 35.3% of people in the ICU compared to 2.6% in the hospitalized non-ICU patients. Major adverse cardiovascular events occur in 45.9% of the ICU patients compared to 6.1% in the hospitalized non-ICU patients. And symptomatic venous thromboembolism occurs in 27% of ICU patients compared to 2.2% of hospitalized non-ICU patients. And remember, this happens despite 85 to 90% of thromboprophylaxis rate. This, as I said, is a very recent registry. And so the vast majority of it were already on thromboprophylaxis. Now, a word about venous thromboembolism. The frequency of venous thromboembolism, as we have seen, is highest in the setting, being around 25 to 27% when you consider symptomatic disease. However, if you do a routine surveillance by venous ultrasonography of all patients, the incidence of VTE rises to 16%, quite significant. Almost 2/3 have venous thrombosis if you go by a venous ultrasonography. And the other difference is that in general, in a sick patient, non-ambulant patient, when we talk about pulmonary embolism, we mean that there is thrombus formation in the deep veins of the legs or pelvis or arms, and then they embolize into the pulmonary circulation. But in COVID, what is found is that local thrombi are formed in the lung vessels due to local inflammatory process. So it is more of a pulmonary thrombosis rather than pulmonary embolism. Now, if you look at the relationship between anticoagulation, mortality, bleeding, and pathology among hospitalized patients, this is again from the US, a single health study, again published very recently. So it is really recent data only. Therapeutic anticoagulation was associated with a 47% reduction in the hazard of in-hospital mortality with a significant p-value. Prophylactic anticoagulation says the same thing. There is a lower hazard of mortality, again, statistically significant. Therapeutic anticoagulation was also associated with a 31% reduction in the hazard of intubation, p-value being 0.02. And prophylactic anticoagulation was similarly associated with a reduced incidence of intubation. So you can see that anticoagulation, whether therapeutic or prophylactic, is not only associated with a reduction in mortality, but is also associated with a reduction in the risk of intubation. Bleeding rates were low overall, unfortunately, but as expected, it will definitely be slightly higher in the therapeutic anticoagulation group compared to the prophylactic anticoagulation group, compared to no anticoagulation group, as is expected. Now, let us see what we should do when a patient comes with COVID, routine testing of all patients. Well, when the patient is hospitalized, all inpatients should have these tests: a complete blood, including a platelet count, coagulation studies, prothrombin time and APTT, fibrinogen and D-dimer. And from this, we get the classical picture of COVID-19 associated coagulopathy, which is a high D-dimer, a high fibrinogen, normal or mildly prolonged PT and APTT, mild thrombocytopenia or thrombocytosis, or normal platelet count. It must be remembered that patients who are not hospitalized, for outpatients, there is no requirement for routine anticoagulation testing. Now, there are also other abnormalities in COVID-19 like raised LDH, increased lactic dehydrogenase, and strikingly high ferritin concentrations, reminiscent of findings in thrombotic microangiopathy. This is very important because ferritin is also an inflammatory marker, and you can see very high ferritin concentrations. And so there are now a consensus of opinion. Many people believe that coagulopathy associated with COVID-19 is a combination of low-grade DIC, localized thrombotic microangiopathy, and that is the reason why ferritin levels are very high. Moreover, interleukin-6, which is again another inflammatory marker, can induce tissue factor expression on mononuclear cells, which subsequently initiates coagulation activation and thrombin generation. Now, coming to prophylactic anticoagulation. In late March, the International Society on Thrombosis and Hemostasis recommended that all hospitalized COVID-19 patients, even those not in the ICU, should receive prophylactic dose of low molecular weight heparin unless contraindicated. Among nearly 3,000 patients with COVID-19 admitted in the New York City's Mount Sinai Health System beginning in mid-March, median survival increased from 14 days to 21 days when anticoagulation was added to this group of patients. The results were particularly striking among sicker patients. So the sicker the patient is, more the benefit is, who required mechanical ventilation, in whom the in-hospital mortality fell from 62.7% to 29%. So patients on mechanical ventilation benefited even more by prophylactic anticoagulation. And the median survival jumped from 9 days to 21 days. Now this result, this association with anticoagulation and improved survival remained even after adjusting for mechanical ventilation. Of course, one has to pay a price, and the price was hemorrhagic stroke, which was significantly increased with the use of anticoagulation, but still was reasonable and not very high. So let us look at the management strategy in patients with COVID-19. Well, we will divide patients into outpatients and inpatients. And inpatients are further divided into those in the ward and those in the ICU. Those in the ICU, we have divided into 3 groups: confirmed venous thromboembolism, presumed pulmonary embolism, and patients with ARDS. Well, all inpatients should have the coagulation test, which I mentioned earlier has to be done. Whereas in the outpatient setting, there is no need for coagulation tests. Now, prophylactic standard dose vitamin D, venous thromboembolism should be considered in outpatients if they are high risk, like obesity or bedridden or something like that, or past history of venous thromboembolism. But it should definitely be given in all inpatients admitted to the ward. This is prophylactic, standard prophylactic venous thromboembolism dose of low molecular weight heparin. Now, when you consider escalated dose of VTE prophylaxis, now VTE prophylaxis dose they have divided into standard dose, escalated dose, and therapeutic dose. The escalated dose, which means higher than the prophylactic dose, should be given in all patients admitted to the ICU, especially those who are having signs of adult respiratory distress syndrome. And finally, you give therapeutic dose anticoagulation in patients with either confirmed VTE or presumed pulmonary embolism. Now, what about post-discharge, extended post-discharge VTE prophylaxis? Well, extended prophylaxis can be given with either low molecular weight heparins or with direct oral anticoagulant. There is no data specific to COVID-19 so far. As I said earlier, we really do not know what is the protocol, what should be the protocol. But translating from whatever data that we have in non-COVID-19 situation, what is best is to risk stratify the patient individually for both thrombotic and hemorrhagic risk, and give extended prophylaxis for 45 days for patients with elevated risk of venous thromboembolism. For example, reduced mobility, comorbidities such as cancer, or D-dimer more than 2 times the upper limit of normal, and of course, patients who have low risk of bleeding. Now, what about patients who are quarantined with mild COVID-19, not hospitalized, but they are quarantined? Well, these patients, thromboprophylaxis is indicated in those with significant comorbidities, not routinely, only those with comorbidities, which makes them at risk for venous thromboembolism. Uncertain in patients without COVID-19. If you are just quarantining with suspicious COVID-19 or because he is a primary contact, it is really uncertain unless they are less active because of quarantine. So what should be done is to advise these patients to stay active at home. Even quarantine patients with mild COVID-19 should be advised to stay active so that you can avoid venous thromboembolism prophylaxis. In the absence of high quality data, the current concept is that pharmacological prophylaxis should be reserved only for those patients at high risk. So not routinely. It should not be given routinely, including those with limited mobility, history of prior VTI or active malignancy. So only these patients should be put on pharmacological prophylaxis in quarantined patients with mild COVID-19. Now coming to arterial thrombosis, let's deal with STEMI and COVID-19. Whatever data we have with STEMI and COVID-19 shows that in STEMI in patients with COVID-19, there is higher incidence of multiple thrombotic culprit lesions. There is higher incidence of stent thrombosis as well as a higher thrombus grade. And there is also lower myocardial blush, suggesting extensive arterial thrombosis also. There has been need for increased use of GP2B3A inhibition and thrombus aspiration. And it has been found that the levels of D-dimer correlates with the thrombus grade, correlates with the myocardial blush grade, and correlates with the level of heparin requirement during the primary PCI procedure. So you can see it here. This is again JARC data. In-hospital mortality is higher for COVID-19, but you can see that the p-value is not significant. Intensive care admission is higher for COVID-19 and the p-value is significant. And admission length for COVID-19 patients with STEMI is also higher, and you can see that it is a significant p-value also. Stent thrombosis is higher with STEMI and COVID-19. Again, you can see the significant p-value. Multivessel thrombus is much higher in patients with STEMI and COVID-19. And modified thrombus grade 4 and 5, higher thrombus burden, is also seen more commonly in patients with STEMI and COVID-19. And it translates to lower myocardial blush grade 2 to 3. You can see it is much lower in patients with STEMI and COVID-19 with a significant p-value. And all these correlate directly with the levels of D-dimer. Higher the D-dimer level, all these thrombotic occlusions also. So to conclude, my dear friends, VTE prophylaxis or anticoagulation, prophylactic anticoagulation is not required in the sets, that is asymptomatic tested SARS-CoV-2 infection, asymptomatic untested and SARS-CoV-2 infection, or of course to uninfected population. These three groups, prophylaxis with anticoagulation is required. However, VTE with prophylaxis, if there is no contraindication, is recommended in mild, moderate to severe and COVID-19, severe COVID-19 patients. Maybe in the mild COVID-19 patients, in the very mild patients who are active, you need not give VTE prophylaxis. But the consensus is that most patients, especially if they are hospitalized, should be on VTE prophylaxis. And the dose of VTE prophylaxis, whether you should give standard doses or escalated doses, will depend on the potential for increased risk of VTE and adverse outcomes, which are determined by age, bedridden status, stasis, inflammatory response, level of IL-6, for example, endothelial injury, hemostatic abnormalities like D-dimer, and evidence of DIC. So I conclude with that, and thank you very much for this opportunity. Thank you.